intervention for type 2 diabetic prevention in DOTS primary care, the opportunities for intervention content. Actually, this article mainly focus about the thing that although the effect of changing behavior intervention on diabetic risk has good effect, but this implementation of this lifestyle modification is a very complicated and hard process. And in this article, 13-month intervention on DOTS primary care among the high-risk individual, there is a FIND risk score among the categories, and greater than 13 versus the usual care was done. And the response was measured by asking the question on the behavioral changes of those individuals. It's like losing weight and dietary modification, and their increased physical activity after 18 months with questions. And they were marked as a planner, initiator, and achiever. Planner means like just if I plan that I will be doing exercises, but if I do not do, that means I am a planner. And if I just plan I am doing exercises from tomorrow and just I do it for 1 or 2 days, then I am categorized as initiator. And if I just do like that, I will be losing 4 kg in 1 month. And if I achieve that my goal, then I will be categorized as achiever, according to this study. And the study defines the diabetic mellitus as the serious illness leading severe complication around 552 million individuals in coming 2030. And it focused that changing behavior can prevent or delay the developmental diabetic mellitus of the individual at high risk. The most main factor that hinder is that this process has complications and many barriers in between. The method they use is the individual recruited in January 2008 by 48 general practitioner and 24 nurse from 14 primary care practice in Holland. And individuals who are at high risk, that is greater than 40 and less than 70 years old, less than or equal to 70 years old were recruited. And along with that FIND risk score greater than 13 point, and 1533 individuals were invited for this study. And they use 479 individuals in intervention and 446 in usual care group. Regarding the intervention group, the behavioral change technique was used such as motivational interviewing, goal setting, and developing action plans and barrier identification, interview with the dietitian in between the study period, and 5 objectives were specified. The intervention group were made in such a way that they will be helping by the initiation and boosting up by the GP and nurses. And usual care group were deprived of those those like in intervention group, but they got only the oral information about regarding the diabetic mellitus. And they never really encountered with the general practitioner with the study related matter. Then finally, the weight reduction of at least 5% if the patient is overweight. They really categorize the weight studies in other settings. Physical exercise of moderate to high intensity for 30 minutes, dietary intake less than 30% and saturated fat intake less than 10% of the total energy intake, and dietary fiber at least 3.4 gram per. And all the participants were stimulated by the nurses to get their goals and plan to some much extent. And all the before this study, those general practitioner and nurse were also well trained and given instruction about the theoretical framework of this study. After 18 months, all the individuals were given the questionnaire, and response rate was quite good, 92% response in intervention group and 85 among the care group. If they answer yes about the changing behavior, they are asked about their group, like I previously mentioned, if they are under the planner, initiator or achiever. And they were actually, the study defined the two barriers, the most barrier, that is motivational barrier, and the motivational barrier is actually collected from the non-planner group, and the volitional barrier were collected from the initiator and achiever. Regarding the statistical analysis, chi-square test was used as PSS program. A p-value of less than 0.05 was considered, and adjustment were done for multiple comparison and was investigated. And finally, regarding result, although no significant baseline characteristic among sex, education, age, Friedrichs score, smoking, and clinical measure like mean BMI, fasting, and 2-hour glucose values. The percentage of planner 76% to 85% in both group were observed. Regarding the initiation, 70% to 86% in the intervention group, and in the usual care group 59 to 79, a bit low, quite low than in intervention group. In achiever were 81 to 95% in intervention group and 83 to 93% in usual care group, almost equal. For losing weight, 67% intervention group and 62% usual care group. Similarly, the study focused the main barrier for the planning change was like that it gives some line like the participants say, I already meet the standard, especially applied to the dietary fiber. When asked about the are you continue the dietary fiber and your physical activity, some of the participants just focused, I already meet the standard, this is the standard for me. The another thing was I am satisfied with my health and behavior regarding the weight intervention, 26% among the caregiver and 35% the intervention. For the weight loss and physical activity, continuity was the main barrier because lack of continuity is the main barrier. For weight loss and fat related objective, temptation to snacks was the important barrier. Just like they are not well tempted to uplift the barrier between the initiator and achiever. And lack of time was a barrier for increased physical activities. I think in this regarding this study, the behavioral change phase and their barrier was assessed in this study. Regarding the motivational phase, that is the planning change, the participants suggest the individual are motivated to change their lifestyle, and the number of non-planner was quite low in both group for all the objective. Non-planner convince their health is an inability of participant to correctly interpret the lifestyle, so that they should be properly informed about their health behavior and they should be properly uplift their plans and setting the goals. And regarding the action phase, the majority of initiators achieved change regarding the diet and physical activity. Lack of main concern was the lack of continuity, and this was considered the main barrier. Inability to resist temptation was also the another rule. And regarding the strength and limitation of this study, it defines that the study provided insight in the black box between intervention on the one side and effectiveness in the other. During the period, although there were missing data, dropouts, and individual diagnosis with the diabetic may have influenced participation outcome, the study has excluded the patient with diabetic mellitus diagnosed during the course of the during the course of the study, and at the end of the study they have excluded the diabetic mellitus cases. More focus on barrier to change may overshadow the development of in the overtime, I guess. And regarding the conclusion, better insight into the behavioral change can contribute better adapted and effective intervention for the diabetes. For further good result, small step approach instruction about the standard reflecting the healthy lifestyle and tools for measuring the healthy lifestyle and goal setting, action planning, engaging the social support and control of the environment and psychological stimuli can be put in the practice. And I think this study has quite well described about the cases of the diabetic mellitus, and main it describes that the main thing is that although although the individuals are majority of the individuals are in the planner group, but quite few only ends up being achiever. And for this, I think the better planning and regarding the health and other things, it should not be like that. I think it should be like that. Doing exercises and having the good health lifestyle should be the habit of the individuals, and then one day I think we can achieve the better result. And this is the just a study, and just it is the kind of initiation, but I think it will take a long time, and more studies should be done, and intervention and more educating the people should be done so as to achieve the good result in diabetic mellitus in the near future.
Can you apply this in your country?
Main thing, yeah, we can apply in my country, I guess, but main thing is that how to uplift the individuals till the achiever group. And for this, I guess, if we make the healthy lifestyle and lifestyle modification a habit of the person, not for the person should realize that it is not the compulsory, but if they realize that the good lifestyle and healthy habit is being their habit, then only they can achieve something. For this, all the individuals should be taught about the exercise, lifestyle modification from the school, junior school. Then only they can take their lifestyle and habit when they get older, because diabetic mellitus 2 is generally found after 40 years. So if the people realize, or if the people make the good health and exercise and lifestyle modification their habit, then what you can achieve. Moreover, we can also use media and use the role models about this modification, then only you can achieve. But it is quite complicated process.
Any question for him? You are reading the paper, right?
Fine.
I think that the paper is quite systematic intervention, because they separate people into group and see the level of their plan action. Then we move to the next paper. Does parental and adolescent participation in an e-health lifestyle modification?
I'm sorry, but I have a question. I'm
Good morning, everyone. So I would like to present behavior modification, and then the paper that I review is that does parental and adolescent participation in an e-health lifestyle modification intervention improve weight outcome. So this journal is from BMC Public Health and was published in 2017. So this is the objective. The objective is, but the study was to determine whether adolescents and parental adherence to competence and an e-health intervention resulted in change in adolescents' body mass index and waist circumference in a sample of overweight or obese adolescents. So briefly, the method is like here. So there are 159 overweight or obese adolescents and their parents. They are followed up for 8 months of intervention. So they have to log in the website that the researcher already designed, and they have to report each week about their dietary and physical activity and like a sedentary behavior also. So, and after 8 months of follow-up, approximately 33 weeks, the researcher will examine the participations, weeks of login in the website, and also about the self-monitoring rates. So these are the results from the table 2 in my left hand side. It's the adolescents. So actually between adolescents and parents, they have a similar pattern, because the number of we log in into the website is quite high for the mean of 13.4, whereas parents is quite low, 7.5. But in their participation rate and also self-monitoring rate, they share a similar pattern. So they seems quite they participate mostly highly in the baseline for first 4 months, and then they will decrease into the 4 until 8 months of follow-up, and to the end the rates of participation is getting higher again. So all of them between parents and adolescents only participate mostly in the first 4 months. And then these are the table of parents' participation. Then the researcher found that 10% increase in parents' participation rate was associated with 6.1% increase adolescents' participation, and also in 10% increase in parents' self-monitoring was associated with 5.4 increase in adolescents' monitoring. This is the result from the Linear-Mixed model predicting the BMI score. So there was an association in decreasing of BMI in patient with high participation, 3,381, and also there are association between the BMI score and also self-monitoring and the waist circumference Z-zone. So briefly, the conclusion of this paper that they said a dose-response relationship between adolescents and participations to an health intervention with decreasing the BMI score, and parental participation also influenced the adolescents' participation to join the e-health, but did not influence the reduction of adolescents' BMI. And the researchers suggest that the improvement of these adolescents, this result might suggest that e-health lifestyle intervention can be an effective strategy to address overweight and obese and adolescents. However, they found that there is a contrary in this expectation because parental participation did not influence anything in the outcome, which is the decreasing of BMI. So they said that the finding contradicts what others have found as family-based intervention have improved the success of traditional clinical interventions. So these are what I assume. The first one is dieting is demands deprivation. Deprivation means that the feeling that you miss something. I mean, diet is really hard for some people, for me also. So when we started a diet, maybe we can maintain only for 1 to 2 weeks maybe, and then we start to craving on something, and then the diet breaks. And then also the second one is because there is an association between eating and emotion. So some people eat because they bored. Some people eat because they stressed. Even they don't do anything, so I feel hungry. Because she's actually not hungry, but she's just bored. That's the problem. And then the third is the lack of support system from parents, relatives, and friends. Talking about body weight is really, what can I say? It's really sensitive for girls. And then, the support system should communicate the way how it's actually related to the fourth one. How to our support system communicate and strategy to engage the adolescents, because adolescents, in a teenager age, really emotional and really sensitive. So it is important to know how the way to communicate and how the strategy to communicate with them. And then the fifth one is the environment. So, since it's adolescents, maybe workplace is not included, but also the school. So, if I'm not mistaken, we've been talking about the difference between weight in the office, like if we have printer in our room, and again, as we can imagine that if we sending our workplace or home, like the study that we've been known before, the setting of our workplace, home or school is really important. Environment is not also it's not generally related to the workplace, home or school also, but also when we walk through especially in Bangkok, I can find street food everywhere. So it's really tempting, like the environment is not good for some people that want to lose weight. So the environment is not only for workplace, how you sit in your school desk, but also in the outside. That's what I'm thinking. Thank you.
Want to add something else? Yeah.
For me, in my opinion, right, in this paper, they said about parents' intervention, and they asked the parent to also submit via online. But what I see lacking is that we have to log in every week, in which is increase the recall bias for this kind of applications. For example, in our smartphone, right, we can download certain kind of applications like this kind of e-health, but you have to fill in every single meal you eat. Even I try to do those kind of applications like 30 minutes after I had my meal and I forgot how much sausage I had, or what kind of the ingredients inside my pedawa or whatever. So I think 1 week is pretty long enough, and I think if they want to succeed, it has to be pretty tight, in which every meal you have to look and measure and everything, like what the dietitian try to manage. And I think I'm not sure how to judge the parents' intervention in this paper, because they ask the parents in every week, and I'm not sure, is it the parents who logged in, or they ask their children to log in for their parents? Because they don't have certain kind of amount to judge whether this is the real parents who answer those kind of system, right? So I think it is best if you can manage with the real follow-up to the clinic. I think it will increase the endurance and the weight circumference decrease also in adolescents. Thank you. So this paper actually lasted for 8 months, and then each month they have to log in, which is, I'm not pretty sure that they really did that. However, still the statistics say they logged in, but I'm not sure whether they follow it like in reality. And also the researcher only visit them for one for 2 weeks to measure their BMI. But still the participation, it's not I'm not really sure about the association right here, because it's really complicated to understand, like, whether do they really log in, is this the subject that really log into the website? I'm not really sure also about that.
Well, when you go to do this kind of things, you can review literature and see the weak point and the positive point of those intervention and apply to your situation. I don't think any intervention is perfect for every parent. Health might not be appropriate in Thailand and in Nepal or in Indonesia. And she mentioned, we don't really know whether the parents log in or the children log in. So that's something. And if we can have very accurate information, will be better hearing. Anything else? Yes.
I think the other problem for this type of intervention is participant-led. You can see that after 4 months, it's less than half of the staff.
The first and the last.
I think maybe for adolescents, you can do like friends, buddy, maybe better than parents,
Right.
because parents have less compliance, and children, adolescents, they don't listen to parents. They listen to their friend. Maybe if you do parties, you get more participation.
That's another thing that you have to consider whether it's appropriate in this group. Another thing is that when you do things like this, you have to keep in mind that the dropout rate going to be the problem in any intervention. Even you have very good monitoring system, the dropout rate going to be problem in anything that you do, not only intervention. All right. Okay, let's move to the paper on perceived barriers and facilitators of using dietary modification.
Good morning, Azan. Good morning, friends. My paper is about, this article is about perceived barrier and facilitator of using dietary modification for CKD prevention among African Americans of low socioeconomic status of qualitative study. In this study, it's about dietary modification among risks of CKD patients, in which they have assess barriers which is perceived by the African Americans of low socioeconomic status, and it is done in Africa, and as already mentioned in the title, among African Americans with low socioeconomic status and who are at high risk for CKD. So it is a qualitative study, and the objective of the study is to assess their CKD knowledge as well as their perceived barrier and facilitator of CKD prevention through changes in dietary practice. The sample size is very low, it is just 17, and it is done in a focus group with questionnaires. And the inclusion criteria was like this: participant with age 18 to 60 years, and those who do not have history of CKD but has family history of CKD and has some risk factor like non-hypertension, cardiovascular disease in the participation, as well as with low socioeconomic status that is defined as one or more of either less than high school education, unemployment, of lack of health insurance, or annual income less than $25,000. So those participants were included who had diagnosis of CKD. And it was assessed through questionnaire which was based on socio-demographic information including age, gender, education, insurance status, employment, annual income, and healthcare utilization. And for personal perception, there was a questionnaire which was divided into 3 sections. It was under knowledge and beliefs of the participants and what are their needs and acceptable interventions. And this was all what participant perceived as. So along with the asked questionnaire, they also provided the information regarding what is kidney, what is its functions, and what are the factors for chronic kidney disease. The information was also provided. And the participants were asked about the DASH diet. DASH diet is a diet which is rich in fruits, vegetables, and low-fat diet foods, and low in salt and saturated fat. And it is good diet to follow for lowering your chance of getting kidney disease. So the questionnaire was like this: under the patient beliefs and knowledge, the questionnaire was not all the questionnaire are mentioned, but just 1-2 example is mentioned. And questionnaires like, do you think what you eat can affect your chance of getting kidney disease? If so, how? So this was under the beliefs and knowledge for the participation. Similarly, for the needs, what do you think you need in order to be able to follow a DASH diet? This was under the need.
And for interventions, if someone wanted to teach how to follow the day's diet, what person that would be, something like this. This were the example of the questionnaire, and I think it doesn't matter here. The matter here is the result. It was a qualitative research, so everything is conceptualized with the grounded theory, and the result here is based on 4 themes, which was conceptualized by the researcher. It was like when asked about the knowledge about the kidney disease causes and risk factors, participants said that chronic kidney disease can be caused by medication or inadequate water intake. Similarly, next thing participants said was chronic kidney CKD can be caused by frequent consumption of certain foods. CKD can be caused by other chronic disease, and family history and ethnicity are the risk factor for CKD. And for perceived barrier to CKD prevention through dietary changes, in those points what participant mentioned was healthy foods are expensive and unavailable in certain neighborhoods. Unhealthy foods are more convenient to prepare or to assess. Unhealthy dietary patterns have been a lifelong habit, and family members' dietary requirement and preference changes ability to change habit. And on asking what could be done for these barriers, the answer was education and nutritional counseling could be done. Raising CKD awareness is the best, and home-based and family intervention to increase diet adherence, and community-based interventions. Let's say in something in detail about the acceptable. In educational and nutritional counseling, participants reported that they believe the ideal person to educate them and recommend the dietary changes that include doctor, nutrition, dietitian or social worker. But social workers should also follow the same diet if they teach them to follow. Unless they do the same, they are not going to follow them. The response was like this. And raising CKD awareness was the next point. So in home-based and family intervention to increase diet adherence, they mentioned that they want those who teach them to go to their family members or go to the kitchen and teach them how to prepare the day's diet so that they can follow them. And in community-based intervention, they mentioned about the acceptable community-based intervention that include community teaching, teaching children about healthful eating at schools, church-based activity and support groups. And they also mentioned about how to group intervention health in home that would help to establish a supportive network. And they also mentioned about the food voucher and other financial interventions. As they already mentioned in the barrier that the economic factor is also one of the barrier for them. They mentioned about the food voucher and other financial interventions would help the needy person who are being the victim because of the economical condition. So to conclude, the African American of low socioeconomic status who are at high risk for developing CKD demonstrated limited perception of their risk status, but identify multiple barriers and potential facilitators of CKD by dietary modification, which can inform tailored intervention and public health initiatives. And after this article, I think this perceived barrier is not only for African with low socioeconomic status, this is for our country as well. I think to all of us, some points maybe for all of us like unhealthy dietary practice has been a long life habit. It's that we follow it from the childhood, and at this point if someone tells us, like I can give my example, I have been eating all fried foods, all spicy foods, and if someone comes here and at this point tells me to eat some boiled food, I won't be able to. Maybe that is the one of the barriers for everyone. And the next is family dietary requirement and preference challenge ability to change habit is also the one that is I think applicable for everyone because in the family we have many members and some prefer some kind of food, some prefer some kind of food, and we don't like to cook every kind of food for different persons. So we better eat what is made, what is preferred by our older ones. So that could be not only applicable for the African but to us as well. Yes, thank you.
Any issue you want to respond to her?
In addition of the motivation, we may have to look at the environment also because this study done in Baltimore, one of the biggest city in US that have the African American people, and most of them are not very good income. If you have less than 10,000 a year, you are very poor, and it's difficult to live in Baltimore because it's expensive city. And if you earn this money, you have no way to get healthy food because you can finish a meal with $1, but it's junk food. To get healthy food, you need to have like $5-10, and you need to cook. If you want to eat in the restaurant with the healthy food, you need 20. It's impossible to pay 20 for them. So they go with the easy choice, $1 per meal. This is always the junk food. If you are the state government and you need to do something for them, maybe the food coupon is the best choice. Instead of giving them like, for example, $300 a month, we may like divide it like, okay, you spend $50 for eggs, $50 for milk. You cannot buy junk food with this portion. Some states doing like this, you can only use this money for fresh food, not junk food. And this is like the way you guide them because these people live on the food portion.
I also like to add, I agree with that, but actually the two main reason for they are not having healthy food, I think is there's a except in addition to the socio-economic standing, also the accessibility of the food. So actually, to my mind, healthy food is not expensive for what I think, but the access to the healthy food is make them more expensive. It's just like that's why they prefer to choose junk food or fast food because it's everywhere. So and make them cheaper because there are a lot of choices of it. Whereas the healthy food is really hard to find. It's not expensive, but it's hard to find, which is makes the price rising up. So I think it is really important to have they have a nutritionist to consult with them. So how they can assess the healthy food without spending so much money. That's what I'm thinking.
Yeah, I think healthy food is not expensive, but the how to assess and how to prepare it is the thing that people are unknown about. So with the same money, how can we make healthy food is the most important thing, I guess, because in Nepal it's not so cheaper to buy junk food than the healthy food because everyone has their farm and so they can do by themselves. But the thing is they are being lazy or they are being attracted by the Western foods and so on that they forget about their farm, they go to the market. That is the, I think, easiest thing they are doing rather than thinking that that is expensive. So I think with the money they have, they can prepare a healthy food rather than buying a junk food.
I didn't agree with that. Okay, the accessible is one problem. Yeah, I agree with that, but I still think that the real healthy food is expensive. So if it's cheap, why we have no a lot of food stores that sell the healthy food? I think because the real healthy food is expensive. It's like you need a lot of the grain in that meal and the vegetable. Okay, it's good, but the good fiber. But if you would like the vegetable that clean from any contamination from the pesticide, I think cost is very high. So that's why if you would like to sell the healthy food, it's expensive. So not every people can sell that, and not every people can buy that. So I think the cost is still the problem.
For me, I also agree with Amarin that I disagree that actually the access to healthy food is difficult. I agree that actually it's everywhere, but for my experience, I work in a primary healthcare who also promotes about the DASH diet and a healthy lifestyle. When I try to interview the participants, right? They prefer the junk food because they're tastier. They're not just fries. They're tastier and they're easy to get. Actually, when you pass the food stall or hawker, it's easier to get just to eat there than you prepare by yourself. That is why I think the feasibility itself is a problem here, and I agree with Chanika with the food coupon, but actually we never did a food coupon before, and in Indonesia I don't think it's a what to say, it's a familiar thing to do in Indonesia, even in a shelter for homeless people. We don't have many shelter, but from what I saw that we have sometimes a visit to that kind of shelter, but we never see any voucher, any food coupon, but they ask the homeless people to come and eat with them. But actually, they want something more because like the westernized food also, like Saru said, it's fancy, right? Everyone snap things and put in Instagram and oh hello, I'm eating burger cake right now. So I think that's what it's in a Western country. It's more difficult to promote and junk food is everywhere, and like literally like some states is promoting their junk food like their burgers, their whatever, but it's even difficult. And for the pricey vegetables or fruits, I think it's because they label themselves as organics and free of pesticide. That is why it's difficult. But if you want to, you can grow it themselves, or if you want, just at least help them to get the more vegetables and more healthy food first, and then if they can achieve, they can buy and have extra money, they can have the organics. But I think just to promote the healthy lifestyle first is important.
Yes.
I have different perspective from the author because I have experience in a family pharmacy at the Ang Thong province, and I interview about the low socio-economic. Almost they work as a construct worker or a farmer labor, and they said that that's diet they don't know, and vegetable or something like a healthy not provide the energy for them. They want the energy to work, and they need the money for preserve their life. They don't want any vegetable or food. They need the energy like sugar, water, something like that. I ever suggest them to change behavior to intake fruits or vegetable, but they said that they not have energy to do work, and this is the problem of it.
Yeah, I agree with you all. See, eating food is is one of the major activity in our life, right? And we happy to eat something that we like and in the culture. Right? We go up with this kind of thing. And when you're talking about Western food, it's like everybody try to be modernized. To eat Western food is to be modernized, right? That's one way. And how many of us concerned with healthy food here? How many? If you agree, you just, okay, I agree with healthy food. But do you have healthy food? Even us. Not all of you concerned with healthy food. Not all of you have healthy food in your meal. Right? How would you expect lay people to have a concern with healthy food? I think the first thing you have to do is build their concern. See, eating habit, we know that is very affecting our health, right? And nowadays the disease is more concerned with chronic degenerative disease, and it relates closely with eating. Somehow, some way, we have to modify this kind of behavior, and it's very difficult. You born with this kind of food. Like you don't really want to eat Thai food every day. Even some of you like it, but you want to have your food. So it's very difficult to change. And I don't think the government going to put a lot of money and effort on this. Like I mentioned, even we as a healthcare provider, not all of us concerned with this. Right? Another thing is exercise. We all know that it's difficult. Let other people do it. Right? Okay, let's move on. Relationships among medication, adherence, lifestyle modification, and health-related quality of life.
Good morning everyone. Today I would like to summarize about the article relationship among medication adherence, lifestyle modification and health-related quality of life in patients with acute myocardial infarction. This article is studied in South Korea with the objective to assess the relationship between medication adherence and lifestyle modification and health-related quality of life among post-acute myocardial infarction patients. From the previous study, they found that in patients with acute MI, comprehensive management of risk factors to lifestyle modification such as smoking cessation, weight control, or physical activity are essential for the improvement of survival and for the prevention of recurrent cardiovascular events. The possible reason for the different outcome in this patient can be explained by the healthy adherence effect, which means that the phenomenon in which patients who adhere to therapy tend to pursue health-seeking behaviors. However, the presence and extent of the healthy adherence effect cannot be easily assessed in a study population. Thus, the authors aim to evaluate whether the relationship between medication adherence and lifestyle modification exists among post-acute myocardial infarction patients treated with PCI. For the methodology, this study is a cross-sectional study which was conducted in 417 post-acute myocardial infarction patients patient were recruited from 11 university hospital from South Korea, and detail regarding socio-demographic factor, sick health behaviors, medication adherence, and quality of life were surveyed in a one-on-one interview by trainers. And the participants were asked about the following sick health behaviors such as 1. Low salt diet, 2. Low salt diet, and all weight loss diet. 3. Regular exercise, 3. Stress reduction in daily life, 5. Drinking in moderation, and 6. Smoking cessation. Then we based on like a scale, it's like never, rarely, sometimes, very often, and always. And those who answer very often or always for each patient was considered to have a high adherence to each health-related behavior. And for self-reported medication adherence, the author used the modified Moresky scale, which presents in 6 items for measure to domain of adherence about knowledge and motivation. The score is ranged from 0 to 3 for each domain, and total score is about 0 to 6, and a high score indicates high adherence. Quality of life of post-acute myocardial infarction was measured using the coronary revascularization outcome questionnaire, which have an advantage in this can assess not only quality of life but also adverse effect of coronary revascularization. For the result, adherence to lifestyle modification tend to be higher in females, older age, and those who have married, had less education, and had a low family income and were unemployed, as they described in Table 1. And according to Table 2, MMS total and MMS knowledge were significantly associated with adherence to lifestyle modification. And among the 6 lifestyle modification, MMS knowledge is more associated with a low fat diet and always low diet and drinking in moderation. And on the other hand, MMS motivation was significantly associated with a low salt diet and low salt diet and always loss, stress reduction, drinking in moderation, and smoking cessation. And in the universal logistic analysis, female older age with greater than 70 years and high MMS score is greater than 5, and quality of life were associated with adherence to lifestyle modification. And for the multiple logistic analysis, a high MMS score was associated with adherence to lifestyle modification. And after adjusting about the quality of life, the association was remained significant. And the author concluded that adherence to medication was associated with adherence to lifestyle modification. And after adjust for quality of life, the association remains significant. And then they suggest that to improve health outcome in post-acute myocardial infarction patient, early detection of patients with poor adherence to medication and lifestyle modification and motivation education programs to improve adherence are important in these patients. And in my opinion, the poor medical adherence is an important problem that I learned at the previous session. And for the management for patients, especially in chronic disease and life-threatening conditions, the best method to improve adherence is important. Then we need to assess about the reason for the non-adherence, and the lifestyle modification and motivation program is the one method to improve them.
Any response from her?
I think even the adder effect that the author talked about in this paper, I think is quite relevant, and as in practice, I think that's what we see as generally patients who try to perform well, like if adding weight to the treatment, then they generally tend to modify. If we ask them to modify their lifestyle, then they might respond to it more positively. But one particular line in this article I found that quite questionable. It mentions here that even in the RCTs of cardiovascular agent, findings of reduced mortality among good adherers of placebo are likely to be explained by healthy adherer effects. I think it's a little bit questionable because if you are actually doing an RCT, then due to the randomization, I think if there's healthy error effect as well, that will be like equally distributed across both the intervention and the control group. So this line I found like a little bit questionable. Apart from that, I think the effect that has been talked in this article, I think is like I would like to agree with that.
Any other response? No? All right. Okay, let's go to the effects of lifestyle modification on metabolic syndrome.
Okay, my paper is quite straightforward. It said about the lifestyle modification on the metabolic syndrome, and this paper they do the systematic review and meta-analysis. They include the study that randomize the patient to one group of the lifestyle modification, and the other group, the comparator group is just the conventional education program. And the total 8 paper were included in the study. 4 paper is only compare among the diet modification and the conventional education, and the other 4 is the diet combined with the exercise. However, in the detail, the paper that were included in the study, there is some heterogeneity. Like in the paper that mentioned about the diet intervention, there is many different kind of diet. Like some paper use about the Mediterranean style diet that composed of a lot of grain and olive oil, good like bit like that, or some is use the DASH diet that stand for the dietary approach to stop hypertension. But mainly the idea of the diet is low fat, low carbohydrate, and less energy. Try to give the energy less than the daily spend of the patient. And another paper that include the intervention include both diet and lifestyle modification in terms of the exercise. The exercise program still heterogeneous among the study. Some study they like use advice to do the walking or moderate intensity exercise, or some paper they use a coach or trainer to get the patient work out. So there is some different. However, when they pull the effect, you can look at the figure 2 and page number 8. It's significantly for the result. The lifestyle modification group, the result, they have a 2 times higher to resolve the metabolic syndrome, and about the blood pressure, the systolic blood pressure reduced around 6.4 millimeter mercury, and waist circumference reduced 2.7 centimeter. Triglyceride reduced around 12 milligram per deciliter in the intervention group compared to the comparator group. Okay, so this paper concludes that the lifestyle modification is an effective way to treat the metabolic syndrome, and can reduce the severity of the complaint of the metabolic syndrome. However, I would like to mention that the weak point is the first thing is the heterogeneity that I already mentioned before, and the second thing is the risk of bias of the study that included in this paper, because some study did not show clearly how about the allocate concealment or blinding during in that primary study, and but the strong point of this article, this meta-analysis, is that they only include only the randomized control trial. It means that the only somehow high quality study that were included into this study, so it's quite valid. Okay, in my opinion, first I would like to thank Kamon Pat who assigned me to read this paper, because it's like you put the right man to the right job. because one of my job is to take care the obesity patient. I am surgeon. I do some kind, the bariatric surgery to reduce the gastric volume or the bypass of the intestine, to make the patient eat less or absorb less calories. But I would like to say that the important factor behind every success case of after surgery is how they can comply with the lifestyle modification after surgery. Even the surgery is the very effective way to reduce the weight, but if the patient cannot change their eating habit or diet and cannot work out as we recommend, the outcome is not so impressive. I think, in my opinion, in my experience, the patient who get into the surgical clinic to do the bariatric surgery, they usually get some knowledge about how important of the lifestyle modification, but how to maintain, how to get into the healthy habit, old habit die hard, right? So when they start reducing their weight, then maybe sometimes they like cheating, they go back to let themselves go back to old habit. So to maintain that healthy lifestyle modification is another problem, is another important that we have to concern. Thank you.
How do you tell them after surgery?
Okay, actually I tell them before surgery how important of the diet and exercise. But my patient is very big. Sometimes the intensive exercise when they still obese quite difficult. So we have to start from less intensive, and then when they lose more weight, they can do more active exercise. And I also provide some instruction about that they have to take after surgery. They have to eat small meal, chew slowly, and eat less carbohydrate, more fiber, something like that. That I try to emphasize, and because this kind of surgery, I make an appointment every 3 to 6 months, and every time when the weight of the patient did not reduce it good enough or stable, I have to explore how about your diet, and I try to modify them. However, it needs the compliance. We can help them sometimes they may not totally comply with our advice. It's quite difficult, but frequent follow-up may make us detect this problem early and can have a chance to modify them. Give advice.
We have advice for him to make his patient comply with his suggestion.
Actually, for his
situation. Even I did not surgery for this kind of surgery, but I think for this problem, we should let the patient motivate about the treatment. The surgery is not solution. Even the previous study for MI, you can see medicine is not solution, but behavior is like to walk along with the treatment that I give the patient, right? That for this kind of surgery, I think as I know, you should counseling patient pre-operative phase is very much before you do the surgery, because if they cannot control the diet or control the activity, even the surgery, the outcome is not good. Something like that, because that the pre-operative phase is quite important, even than surgery.
Do you have any people to help you to talk to this patient before?
Because my hospital is quite a small medical school, so we have no experts in the nutrition. We have no nutritionist, so I have to do it by myself. Maybe it's not good enough, but in the big center, they have the expert in the dietary field, so they can give the advice for the patient more effective.
I think you may ask help from psychologists.
Yeah, I try to help from psychologists. That I ask my colleague, hey, you interest in the eating problem, because some eating problem is from the psychiatric component, but they just ignore my message. So okay, maybe they want to treat the major depressive disorder or anxiety disorder, but it's not, or they is not in that field, expertise field. So it seems like I am working alone.
I think you need team.
Yes.
I don't think you can do it alone. No. Probably some nurse who can tell you some of those who convince the patient. Because I don't think you have time to talk to this patient for long.
But before surgery, that first visit, I spend almost half an hour for each patient who is a candidate for the surgery. But maybe it's not enough, because to change the people, that maybe they need more visit or more time.
Or they need something that more convincing.
Yes.
Not only the communication, something that like an example, some people who have experience of obese and then can reduce weight and how they do it.
Yes, I think in the patient who the weight reduce very good, it's like a self motivation. If the weight reduce as a goal, and they feel more comply with the lifestyle modification. But when some patient that the weight is not reduced very much, it's like a vicious cycle. And I plan actually we have planned to build up the bariatric clinic like us. Someone every patient in one session, and it's like a group therapy.
Yeah.
So the good outcome patient can be like a trainer for the newcomer, something like that. But still have some limitation about our office, our clinic is not big enough.
I think they have a lot of example of self-help group
Yes.
in particular disease, so you can use that and come together and talk. I don't know, once a month or twice a month, things like that.
Right now, my hospital new building is almost done, almost finished. So if we move the outpatient department to that building, maybe we have more space to do the group. But I have to finish the program training.
You're going to finish this year, right? This 1 year. Okay, let's move to the last paper.
The last paper is about socio-demographic factors and pregnancy outcomes associated with pre-pregnancy obesity, effect modification of parity in the nationwide epiphany birth cohort. This study is conducted in France. So this is about, as we know that obesity in pregnancy causes many complications to mother and also to the infants. So this paper would like to identify the risk factors of how which risk factor contribute to the obesity in the women who are going to pregnant. They study in 3,368 mothers who had delivered in the hospital, 136 randomly hospital in the France. So they collect the data as shown in the slide. Eligibility criteria, they collect mother whose age more than 18 years and corresponding newborn who was born with the age of more than 33 amenorrhea weeks without severe pathology to the infant, and they measure the outcome of factors including pre-pregnancy BMI and also gestational weight gain, parity, socio-demographic factors including age, educational level, married, health behavior including tobacco, alcohol, and antenatal class attendance, maternal neonatal outcomes including body weight, gestational DM, hypertension, cesarean section, birth weight, and also APGAR score of the children. So the population in this study mostly include the mother who age about 25 to 35 years old. Most of them were born in France with university level education, and half of them were first gestation. So after analyze the association between interesting factors and pre-gestational obesity, they found that younger maternal age and multiparity, also lower maternal education, lower level of maternal occupation, long maternal leave, and no attendance of antenatal classes associated with pre-pregnancy obesity. And for the factors in neonatal and maternal health, they found that GDM and hypertensive complications, also cesarean section and fetal macrosomia associated with prepregnancy obesity. This is the diagram which shows that most of the pregnancy women they were normal weight, but about 10% were obese before pregnant, and 18% were overweight before pregnant. And this is the population that we are interested in this study. And after they found these factors which are associated with prepregnancy obesity, they do the subgroup analysis, compare between multi-parity and and only one parity. So parity that means who have pregnant many times compared to pregnant only for first time. So they found that lower maternal education and no attendance of antenatal classes, also above IOM weight. IOM is this diagram. IOM is the suggestion from Institute of Medicine. How much weight gain should you gain when you are pregnant? So if any women who get weight gain more than this recommendation, they will classify it as the above IOM weight gain. So multiparous compared to primiparous, multiparous has higher odds of having above IOM weight gain and GDM hypertensive complication, also higher rate of cesarean section and fetal macrosomia. So this effect show that there is effect modification of parity in the association between both socio-demographic factors and also maternal neonatal outcome and pre-pregnancy obesity. So this study would like to emphasize that in each group of parity has a different association with socio-demographic and also maternal neonatal outcomes. And we have to tailor the targeting intervention for the mother who have high risk of having pre-gestational obesity. But the limitation of this study is the study was conducted under the cohort and also the questionnaire, so there might be some misinformation and also maybe underestimate some of relation of association, and also we may get recall bias because this is the interview questionnaire after giving birth. And also this study include only uncomplicated delivery, which is normal baby, so we cannot know the association between this risk factor to the pre-pregnancy obesity in the woman who give birth with abnormal baby, like very complicated baby. So we don't know that information. Maybe this risk factor will have even higher odds ratio that more than this paper results. So if we see this kind of result, so maybe we have to think about the targeting intervention to the high-risk group of patients. Like in this study, they recommend that we should pay attention to the multiparous matter who have low socioeconomic and low education to get them involved in more attendance of antenatal classes. You can see that multiparous with gestational obesity always have lower education and also it associated with no attendance of antenatal classes. And then they get above IOM weight gain and GDM hypertensive complication, cesarean section and fetal macrosomia as a result. So in a part of doctors, we may pay attention more for the patients who have high risk like this. So we can prevent also maternal outcome and also infant outcomes because pregnancy always contains like both mother and children. So it's worth that we have to pay attention to this kind of pregnancy. And for targeting intervention, maybe we can build up like a group education for this type of mother. So we can tailor the contents like match to level of education of the mothers and the environment of the mothers, socio-economic like that. And for this, in the discussion part, the author said that the reason why the pregnancy women who get pre-gestational obesity don't come to the antenatal classes because they might feel uncomfortable because of aware of their figures, like negative perception of their figures, and also maybe they have other comorbidities associated with obesity like hypertension or DM before pregnancy, so they are so busy with that clinic and then they don't pay attention with the antenatal class and don't get don't pay attention with their pregnancy. So that's why they don't come to the antenatal classes.
Any response for her? Yes.
I also agree with it is the best thing if we can do intervention for the pre-pregnancy women with obesity, but in the real situation, obesity women may not know but they pregnant or not because they must usually have irregular menstruation and they may have a missed period for about 5 months and they must know quickening and go to an ANC clinic. And if she comes late, the complication is more severe. Yeah. But if they come early, we will let her to high-risk clinic for intervention or this program for prevent about the morbidity for her and her neonatal.
Any other response? Okay. We finished the first part of the course. Next week we're going to do methodology. This first part concerns with the concept of the behavior related to health. And I pick up some of the things that I believe is going to be useful. So there's a lot of concepts. in social behavior related to the, but this just pick it up. And next 2 weeks we go to the methodology part of social science that we can use in health. Any question concerned with concept, you can ask or you can talk or you can discuss. You want to learn anything more?
I think about the concept that we have discussed. I think it's very important, but it is the most difficult part in the healthcare system. Yeah, very difficult to get the people know how important of that factor, how change their life. Very difficult. I think it's important, but it is the most difficult because it's not like you put the treatment that the like a surgery or medication. It's like you have to put more effort into that kind of modify or trigger to let them aware themselves, something like that.
It's very difficult because it's concerned with their culture, their activity, their daily life,
Perspective.
their daily life, their perspective, everything that if you have like a surgery, okay, you can cut this out, right? But to concern with people behavior, you cannot cut them, and they have to behave themselves, right? But all of this is the cause of your problem. It's the cause of the disease, and your activity or your treatment depend on this activity, this behavior. Your treatment going to be unsuccessful if they don't follow your suggestion. And you will get more disease, you will get more workload if they don't change their behavior. Right? So it's very closely related. I think if you concern with all of this, you will be like not really treat the disease. You will treat the patient. The point is you have to treat the patient, not the disease. Right? If you treat the disease, it's coming more and more. But if you treat the patient, you will get less disease.
Actually, we would like to know about the mixed model research because I think it's very helpful in our kind of field and work, and it's not that as very statistic, right? It's not that very complicated. No, and we in my colleague, I don't have a background on mixed model, and because they separated in qualitative and quantitative, so I wondered how to conduct mixed model and how to justify the qualitative itself. It's very interesting.
We're going to have it. The last section going to be mixed method. Okay, and the first 2 sections is qualitative method. I will ask you to read, and we have some example, and we can discuss it. And no statistics.
Yeah, because we came to public health faculty and had a guest lecture, but actually the guest lecturer didn't tell about the mixed modal effect, but autobiography. So it's very sad for us.
Okay, we'll start next week. All right. See you
Thank
next week.
you.